Yes, welcome everyone. Thank you for joining. We're excited to be starting again this series of webinars this year on men and HIV. We're going to swap the agenda around and have Rachel as she has another commitment. So I'll let Rachel come first and then I'll come after you, Rachel. Over to you.
Thank you very, very much, Lysias. And I want to give everyone a really warm welcome to this third webinar, and it's a hugely topical area, men and HIV, and we have really great leaders in this field from WHO and UNAIDS. So thank you, Lysias. Thank you, Wally. And also I can see Afsar from ILO, who's been leading the charge on working with men through the workplace for many, many years. I think men now are really center of the agenda across countries and across the donor agencies. And I was really pleased to see in one of the PEPFAR COPS calls a big push for much more emphasis on ways of supporting men to get tested, to get on treatment, to stay on treatment or re-engage in treatment, as well as, of course, the prevention issues that have really been dominant over the years. But I think now it's a big push for more holistic support for men. So this is going to be really exciting. We have we have two fantastic presenters and on two really exciting topics. Kate Dovell, who's really leading the way on looking at ways to support men who've been lost to follow up and get them back into treatment. And then, of course, really important from Philip Smith on that U=U message. Again, I think we haven't done enough about this in countries to really explain that once you're in treatment, there is absolutely no chance if you're taking your treatment well and you have a suppressed viral load that you can transmit HIV to sexual partners. Really key messages. So this is extremely exciting. Thank you very, very much, participants, for coming. And as I say, WHO is really committed to men being at the centre of the HIV response. It's very much part of our new strategies. And of course, UNAIDS, and I won't speak for UNAIDS, Lysias will do that, but UNAIDS, again, a huge commitment, and the next PCB thematic will be on men. So that's going to be, again, a real flag to show that this is such an important area for us, us at WHO and UNAIDS. So I'll hand back to Lysias. Thank you very, very much for allowing me to say some opening remarks.
Thank you so much, Rachel. Thank you. Just to come back to this webinar, just to highlight that we've got French and Spanish interpretations available. So feel free to check on that globe-looking icon on your screen and select your language of preference from those two. And as we have always done, we are recording this webinar. We will send through the slides and the recording after the webinar. And also we have a very short poll in between the webinar. We'll be interested to hear your thoughts around that. For some who are joining us for the first time, MENT was launched early last year in March. Basically trying to address this gap of HIV services among men, and with these four main objectives, of which one of the objectives we are trying to address it through this series of webinars. So basically to address or to coordinate work around men and HIV across the HIV cascade, and to support advocates' efforts with global partners as well as key stakeholders who are working on this topic. Also to support the development of operational guidance, implementation tools to improve HIV services for men, including identifying any good practices or interventions, as well as reviewing of technical documents. You will see in one of the upcoming episodes of this webinar series, you will also hear from ISA, the framework they developed as a framework for action to focusing on male engagement. Also, we want to make this a platform to share best practices, as I highlighted earlier on, and this is one of the ways we are doing it via the webinar series. We have done 2 so far, and this is the 3rd episode, as Rachel highlighted, and we are looking forward to continuing with this series of webinars and also hearing from you who are implementing any interventions on men and HIV. So if you've got any work around this, feel free to share with us or to highlight with us if you're interested in presenting it during this series of webinars. Rachel has already highlighted to you the agenda for today. And without further ado, I would like to introduce Kate, who is going to take us through understanding who really disengages from care, tracing outcomes and characteristics of men who are lost to follow-up at 20 health facilities in Malawi. Kate has presented before in this series of webinars, and it has been very interesting to learn about this work she's doing with her team in Malawi. So over to you, Kate.
Great, thank you so much, Lycius. I'm just trying to share my screen, and it says I cannot start sharing until you stop.
Yes, I need to stop mine.
Very happy and privileged to join you all today, and so excited to see this this series continuing.
You should be able to share now.
Okay, yes. And let me just put this in presenter. All right, so again, very happy to be with all of you today. And happy to present on behalf of the team, but just to note that I'm presenting on behalf of a very large team that we've been working together for, some of us, nearly a decade around the topic of men and HIV engagement and care. So I'm privileged to be able to represent our larger group here. So we all know that men are at higher risk of disengagement or not engaging at all. But some of what we still don't know as the agenda for men is being taken up within programmatic practices is what is men's disengagement within routine care. And our routine data has some limitations around silent transfer, poor data entry, clients may be disengaging, but then presenting as new clients when they choose to re-engage. And so there is a bit of a gap around understanding within our routine programs, now that men have become a focus, what is the level of disengagement? And as well of those who are truly disengaged, what additional support do they need? And as we think about disengagement, we've been thinking about it as these 3 kind of categories, although certainly these are not completely distinct. There's certainly overlap, and we're finding more and more that it is this cyclical process of disengagement, re-engagement. So people will move throughout these categories during their life course. First is tested HIV positive but not initiated, those who initiate but do not return to care. And we expect that this would be potentially a higher group under same-day start policies where people are initiating right away, but maybe once they return home realize I'm not quite ready. So that's kind of this unique category under test and treat. And then truly defaulted. So this is individuals who were engaged in care, had come to multiple ART appointments, but at some point were 28 or more days late and considered defaulted. The other thing that really we want to be able to understand is, because this is quite a cyclical process and we're seeing more and more of that, really key is not just do people disengage or not, but what happens when they do? How long are individuals out of care? How many events of this engagement, disengagement take place? So we're going to spend some time just exploring that today, and we're going to draw from 2 trials that are currently ongoing within Malawi with this larger group that I talked about earlier. The first trial is Engage, called Engaging Men Through Differentiated Care to Improve ART Initiation and Viral Suppression. This is funded by NIMH. The second is IDEAL. You can see the title here, funded by Bill and Melinda Gates Foundation. Both are in Malawi. Both are enrolling the same type of male participants, men who are living with HIV but not currently engaged in care. And both are currently ongoing. So our team is very busy on the ground. The unique pieces with these two trials are the interventions being tested. Engage is looking at providing 3 months of ART distribution upon enrollment, along with male-tailored counseling. So they're providing these 3 distinct one-on-one interactions with a healthcare worker at home or in the community. And then after that, given a warm handover or a facility navigation to join the larger cohort. IDEAL is looking at a couple different strategies, and we're trying some stepped approaches where the intervention increases over time as it's clear that clients need additional support. And these interventions include male-specific counseling. It includes mentorship and peer mentorship where kind of friendships and ongoing support is built. And it does include home-based ART initiation or reinitiation. So like I said, these are all ongoing. Happy to be able to start sharing some preliminary data around our enrollment and baseline surveys. But overall, we will, at the end of these, have about 1,200 men who are living with HIV but disengaged from care as part of these samples. So within our about 10 minutes or so today, we'll be looking at within these trial settings, what types of men are being reported at facilities as disengaged, and who is actually disengaged using a tracing process. And then of those who are disengaged, what are their characteristics? What are their barriers to care and what's needed? Okay, so quickly, what did we do in terms of tracing? So here you can see our 20 health facilities, and we went through we did a medical chart review at each facility to identify men who fall within one of these 3 categories of disengagement we discussed earlier. If they were recorded or documented in the register as fitting within one of these categories, they were then traced by study staff. And I think it's important to know that they were traced by study staff, not routine healthcare workers. And we attempted to trace them up to 3 times. We then asked to see their personal medical records, to confirm engagement or disengagement from care. And we did rely on self-report if records were not available. However, that was for a small minority of individuals. All right, so what did we find? So we have traced 1,300 men thus far across the 20 health facilities. And really interesting, the vast majority of these men fall within the default category. So they had been in care an extended period of time, had missed an appointment, and had stayed out of care for at least 28 days. We were a bit surprised to see only 3% of individuals identified were this initiated but never returned. And I think there's a couple things going on here just to note. One is the breakdown that you're seeing here is for entire facilities, right? So there's actually, this is absolute number. If we were to look instead at the proportion of men initiating who never return versus the proportion of men who are actively in care and then default, this would likely look very different. And we'd either see similar rates of disengagement between the 2 groups or potentially higher rates of disengagement within those who just newly initiated based on the kind of literature. But this is showing us from a facility perspective, what is the burden or the absolute number of men needed to be traced and to be given additional care. And from a facility perspective, the vast majority of individuals facilities need to reach out to are defaulters. Importantly, very few had phones registered or documented at a health facility. And we found from practice that most were not that useful in being reached anyway. And it did require multiple attempts for tracing. We reached a little over 50% of these men, and most weren't reached from these 3 reasons listed below. Either there was inaccurate or incomplete data on where individuals lived because we were having to trace in person due to limited phone availability. A lot moved outside of the facility catchment area, And then a little less than a quarter were currently traveling at the time that they were attempted to be traced. And we attempted these 3 attempts over the course of a month. So gave a solid amount of time, but still there's actually quite a lot of travel. Among those that we traced, what were their outcomes? And I think this is really important as we think about this idea of disengaged men, or the narrative that is thankfully shifting, but of difficult men. And actually, of those we're able to find, we could confirm 32% were active in care, were not disengaged at all. And actually a good proportion of those were actively in care at the study facility. There was just poor documentation within the facility. We had 61% who were truly disengaged from care. And there was an interesting difference here by category of disengagement. So here we see that our initiated but never returned group, the bar in the middle, I think you can see my cursor, that this group actually had the highest rates of disengagement. And interestingly, never initiated had the lowest rates of disengagement, with the most men actually being active in care. And for the never initiated, this was largely through silent transfer. So they were actively in care at another health facility, which makes sense if you consider some of these men may have been tested at a referral hospital when receiving care for something else, and then moved to maybe a local or a farther away facility when they decided to engage in treatment. All right, so that is just briefly a background there. I think the main thing to highlight from this is that we do have men actively in care that are showing up as defaulters or as disengaged. And how can we have better records and improve our record system to show that? And how can we work at really being able to locate and find these men that are in need? So of those that we found that we confirmed as disengaged, we screened and enrolled them in one of our 2 trials, depending on the health facility and what trial it was allocated to. We then completed a baseline survey that covered an array of topics. You can see some of them listed here. And I want to present to you quickly some of what we found that has some real implications for the type of services these men need. So again, these are confirmed disengaged. So here we see just basic characteristics. Who are we talking about? We're talking about older men. And this should not come as a surprise based on some of the other findings that have been coming out of the field over the last year or so. So we're looking at men in their late 30s, early 40s. Most have been on care an extended period of time. This makes sense since 85% were defaulters, as opposed to those who never truly engaged in care. And a lot, this was not the first time of disengagement. There is this cycle. So 31% reported, and this is self-report for the cycles of disengagement, reported having been out of care before. And what are some of the barriers? What are some of the things these men are experiencing? And unfortunately, you see a lot of red on this slide, and I attempted to cut down all the boxes that we put in red and just couldn't, because all of these things are actually so important. We see really high prevalence of fear, of stigma and discrimination due to unwanted status disclosure. So 73% listed having pretty high fears that if their community, if their friends found out that they were living with HIV, they would experience some type of stigma or discrimination. Most of this is perceived or anticipated stigma, not actually experienced, which I think is important to know. But nonetheless, men are reporting completely changing behavior and developing strategies to avoid this anticipated negative experience. Not surprisingly then, we have 41% who have not disclosed to anyone besides their spouse. And almost everyone disclosed to their primary sexual partner if they had a live-in or marital partner. But 41%, that's the only person that they had disclosed to. And we have 27% that never talked to anyone about HIV. So even if they've disclosed to their sexual partner, they're not having someone who's truly acting as a guardian or someone to give them support throughout their journey on ART. There's still a lot of fear about side effects, and we have the new regimen completely in place in Malawi, as I think throughout the region, but there's still a lot of perceptions of the side effects with older regimens around weight gain, around nausea, around problems with sleep that need to be addressed. And then finally, we have a highly mobile population. 32% were highly mobile, with 60 median nights away from home in the last 12 months. So you can clearly see some major barriers and limits to care listed here. And I just want to deep dive really quick into travel or mobility to give you an example of what this type of barrier means for men. We have a postdoc, Marguerite Thorpe, who is doing a sub-study within these trials specifically around mobility. And it's been amazing to get this on our radar. She's completed, or the team has completed 32 in-depth interviews with these men to understand what's going on. I think really importantly, this is not an issue of men choosing making more money over care. This is men trying to really balance really difficult situations where they have to travel for livelihoods and yet also have to meet pretty rigorous and demanding requirements for routine facility visits. So here, just quickly, we see travel is essential, and you can read through these. I'm running out of time, so I'm going to move quickly. Travel is essential. It's very unpredictable. So most men did not have more than a 2-day notice on when they were going to leave, and most did not know how long they would be gone. And men care about staying on ARVs. We had men make multiple attempts. So down here at the bottom, you can see the different types of attempts men made. They tried to have someone do refills for them. 8 tried to get emergency refills at another facility. 8 just returned from their trip early to go to the facility, but a lot of these didn't work, and they weren't able to be in care. Importantly, those who did disengage due to travel and came back, 12 of them reported that they had rude interactions with providers, and providers questioning them and pushing them regarding why they missed care. All right, and then very quickly here, so what do we do about it? So we also have some 40 in-depth interviews with men across those who either didn't initiate or newly initiated, and those who have been on care for a while, to talk about what facilitates. Just quickly to flag here, positive facility experiences, positive engagement with healthcare workers is key across the cascade. And this has been a huge gap for men historically, because we just haven't seen them within the health facility. They haven't been on anyone's radar. So we have a huge amount of catch up to do in terms of positive facility experiences. You can see that exposure to successful clients. I think we would also say that having someone to just ask questions to would also be critically important here for retention and then support, social support. But as you saw, a lot of these men don't have that support and aren't talking to someone about their HIV status. And just to flag here, while it wasn't mentioned by the individual men, to say that there's also a need to increase access and decrease the stigmatization that happens at visits, either because ART clinics are siloed and the queue can be seen from the road, or people are having to make so many visits that community members will start questioning, oh, why are you going? You must have HIV, right? So certainly for us not to forget that there's a very health systems level barrier here that can be addressed. And that by simply talking to men and improving their social support, that's not going to cut it. We really also need to address these facility level barriers. Okay, I am over my time, but I appreciate being able to talk to all of you. Just some quick summaries. Again, some of these men, 30% of these men we think are disengaged actually are not. They are actively in care. From our baseline, all of the men who have disengaged, the vast majority talk about trying to stay in care and their resiliency and building strategies around how to do so. But there are multiple competing challenges that they're facing. And then we're wanting to dig in more into the cyclical aspect of care, and how, as opposed to saying, let's reduce any disengagement from care, how do we reduce length of disengagement and focus on this re-entry as part of normal ART programs? All right. Thank you all very much for your time. And apologies for going over a little bit. I look forward to talking further.
Thank you. Thank you, Kate. Thank you so much. I see engaging discussions happening in the chat box and some questions coming in the Q&A function. Thank you. Thank you. Keep them coming. And we'll also have a question and answer dedicated session where we can revisit these. While we go through the presentation, the panelists will also be going through these questions and responding to them and feeding back the responses. Without wasting more time, I would like to give to Dr. Philip Smith from the Desmond Tutu Health Foundation. For some of you maybe who didn't know, the Desmond Tutu, former HIV Foundation, now called the Health Foundation. I also learned about this a few weeks ago. Over to you, Philip, on the U equals to U messaging. Thank you.
Thanks very much, Lysias. You can hear me?
Yes, clearly.
Perfect. Yeah, so I'll be presenting the results of our randomized control study on U equals U messaging to increase the uptake of HIV testing. I am also presenting on behalf of some of my colleagues, and I see that Devora Davy is in the room as well. So our question was, can tailored messaging about being U equals U increase HIV testing uptake among men? And so the background to that is that men have lower rates of HIV testing, prevention and treatment compared with their female counterparts, higher rates of HIV infection, morbidity and mortality. So we need solutions to overcome some of those real and perceived barriers. I recall hearing back in 2008 that people don't want to think about their vulnerability. And the specific statement that stands out for me is, we are sick and tired of hearing about AIDS, AIDS, AIDS. So how do we think differently about that? So onto undetectable equals untransmittable. People living with HIV who take ART and have an undetectable viral load can't sexually transmit HIV. So that's a compelling formulation of treatment as prevention messaging. So we wondered about, how do we translate this for men in the South African context? Now, this is a little bit complex, but what I'm showing you here is the co-creation of the U equals U message. So what we did was we took the evidence and we presented that to a group of men here in Cape Town, South Africa, and asked them, how would you present this message to your peers? We then asked them to take those formulations and present them to one another and in short, choose the messages that they thought were more impactful. And then we again got them to present those messages and to iteratively refine those until we got to a place where we had refined it to the extent that we thought it was good to go in community. So these are some of the questions that we asked the men. What might you say to make me confident that I will be HIV safe? And what might we do to convince everyone in your community that I'm HIV safe thanks to this pill? So you'll see there that there were 3 insights. And the first insight was to introduce the modern ARV. The second was to redefine the bad guy. And the third insight was to make it simple. So we published that process of co-creating the U equals U message. So just to emphasize that there were those 3 main insights: to introduce the benefits of the ARV pill, to positively redefine the man for whom the pill is intended, and then to reframe the benefits of ART to be simple and straightforward so that their peers could understand it. So this was the end product, the invitation, down to 1 sentence. U equals U, the pill, reduces HIV so you don't pass it on. I'm going to take some time to read the actual U equals U message that the men put together, because I think it's important to hear these 8 points. It's first to introduce myself, and then to say, do you know about the pill, the latest free ARV pill that you take once a day if you're infected with HIV? Did you know that Mpilo protects you from getting sick because it reduces HIV in the body, so much so that you can't infect your partner and family? This is called U equals U. It protects you even if you don't use a condom, even if you're drinking. Did you know that? So in no time you're a grand, which means fine, and protecting your partner and family. Your life stays the same and doesn't change. You and I can show our kasi how to do this thing one by one, protecting our kasi, kusela ikasi lam, which means protecting our location. The tutu tester can quickly tell you your HIV status, and you can get Mpilo for mahala. Take this invite with you and I'll see you there. So we took that message and we designed our study, which was to invite 4,000 men to test at the tutu tester over 48 days and 6 sites. That's about 100 to 125 invites per day. We had 24 standard messaging days and 24 U equals U days. And the procedure was to have a recruiter, a trained mobilizer, to deliver that message in maybe a similar fashion to the way that I did, to engage the participant, and then to have that participant register at the mobile clinic to test for HIV. And those participants who tested HIV positive were referred for care. And that was the same for the standard of care day. So the COVID-19 lockdown discontinuation meant that we had only delivered 1,049 invites to test at the tutu tester truck over 12 days. We had randomized 5 of the 6 sites, and we had delivered about 100 invites per day. So just to clarify, we had 5 standard messaging days and 7 U equals U days. So the main outcome was that those who had received the U equals U message were almost twice as likely to come in for an HIV test. And the secondary outcome was yield of HIV positive testers, and that was 6% in the U equals U group and 4% in the standard messaging group. So to look at the table 1, there was really just employment that participants differed on. Participants in the standard of care day were more likely to be employed than those in the U equals U. And then there were 3 things to note when comparing the standard of care and the U equals U. So it was interesting that almost 2/3 of the standard of care participants had heard the U equals U message, or at least reported that they had heard that. And also fascinating that almost 1/3 again had said that they had heard it from the promoter, the person who had invited them for the HIV test. So that was interesting to note. And then in the U equals U group, it's important to mention there that upon hearing the message, over half of participants felt relieved to have heard the U equals U message. And then just to recap that that the U equals U message almost doubled the odds of testing for HIV, and the same for being tested. So we looked at that in a stratified way, came in for testing and then actually received an HIV test. So then U equals U knowledge we also looked at U equals U knowledge, and you'll see there that those in the U equals U group reported high U equals U knowledge, and also it wasn't statistically significant, but there was high level of knowledge of the U equals U as well. And then there was no difference in belief about HIV transmission. You'll see that the standard messaging was higher, which is fascinating in the standard group. So the U equals U message doubled HIV testing. There was slightly lower U equals U comprehension in the U equals U group, and so we wondered a little bit about that, about this counterintuitive finding, and might it have been social desirability? Participants were telling us what we thought we might want to hear. Was there possible contamination? It's possible that they might have heard the formulation from friends or have received the message on a previous day, and so had heard the message from us before that. Then some of the limitations is that our sample size was reduced to a quarter. The counterintuitive findings may resolve with a more appropriate sample size. And then we thought about going back and asking open-ended questions about that understanding. So you know, what was it about the message that motivated attendance at the Tutu tester? Was it something about the way the message was delivered? Was it the content of the message, the actual U equals U formulation? So we were interested to, you know, understand the mechanisms that shifted behavior. And then finally, just to recap, U equals U significantly improved HIV testing uptake, and reported knowledge about U equals U was high in both groups, and U equals U also yielded higher HIV positive diagnoses. And then the one thing was that referrals often lack contact details, so it was difficult to follow up with all of those participants. So again, thank you very much for listening and for your time.
Thank you so much, Philip. Thanks for the excellent presentation, excellent data coming from this study. I see interesting discussions happening in the chat box, and also some interesting questions coming through the Q&A function. We are excited to see how excited the participants are on this topic. So we'd like to find out if we can just take 1 minute of your time to run through a very short poll, which is just one question. We want to be able to know among us, those who are working on men and HIV, if you are interested in any work that you're interested in sharing in this platform. I would like to ask our IT person to just launch one poll question. It's just one simple multiple choice question, which we can always follow up based on your responses. And Nicola, if you are there, if you can launch the poll question.
Sorry, Lysis, you'd like me to share one question in the question and answer?
Yeah, if you can launch the poll.
Oh, the poll. Okay,
yes.
sure.
Thank you. We basically want to know those who are, you put any data they would like to share during this platform. So it's just a simple multiple choice question. Thank you. I see responses coming. Okay, quite a number indicating that you have some data that you're interested in sharing in one of these episodes of this series of webinars. Wole, when he does the closing remarks, is going to share the schedule for the next upcoming webinars, and we'll follow up with you based on your response to see where we can slot in what you're interested in sharing in these webinars. Thanks for responding. Okay, I think there's a pause in responses coming in. You can close the pool. I think I've got quite a number of people interested in this, which is great. Thank you. Thank you. 57% are indicating that they are interested in sharing their data on this platform. We'll follow up, we'll extract the individual response for this poll, and then we'll follow up with you and schedule on which episode you can present your work. So without wasting more time, I'd like to hand over to Afsa. Afsa from ILO. As you know, ILO does a lot of work on men and HIV, especially in the workplace. So Afsa is going to facilitate the Q&A session for us. Over to you, Afsa.
Thank you very much, Lisas, and thank you, colleagues. Very insightful presentations by both our presenters. And I really want to thank our participants who have been also already writing some questions in the chat box, which are very important. I would like to maybe ask one or two questions, and I'll pick up some questions from the chat, and the ones which I'm also going to ask is in the spirit of what I see in the chat box. When I see presentation that's made by Catherine from Malawi on the level of engagement or disengagement of men, what we are seeing that there's a large percentage, about 74% men who get initiated, but they never return to the follow-up category. So what, I mean, you did flag out a few issues, but could you mention from your perspective, what are top one or two main reasons for this situation, Catherine? Could you please make a quick response to that?
Yeah, thank you for the question. So in terms of men who initiate and then never return, we're actually seeing at least less of the facility level population falling within that category. And I think part of the reason why we're not seeing as much immediate disengagement right after initiation is there has been a lot of effort on the ground programmatically with the Ministry of Health, with PEPFAR partners to focus some more attention on the first 6 months after initiation. And individuals who initiate are given a counselor or a kind of a caseworker of sorts who follows up with them prior to their next appointment and is kind of helping them navigate the program more than what used to happen in the past. So I think that may be part of what we're seeing there, but needs further exploration.
Okay, and another interesting thing that I noticed in your presentation is the factor that is attributed to mobility. That this is one of the main reasons why they kind of get disengaged because of mobility. So the question here is, and I also saw a nice question about it to elaborate a little bit more on this, but my question to you would be the sample size that you had, about over 200 men. Did you capture their work profile, some information about where do they work, which kind of sectors do they work? Because that would help us maybe have more interventions to engage better at the place of work as well.
Yeah, great question. So it's the mobility piece is really interesting. It's something that wasn't on our radar when we first started this, and so grateful to have some really good folks working on it. I'm actually going to just post in the chat to everyone a response from our postdoc, Marguerite Thorpe, who's leading the mobility piece. So you can see that in the chat box. But in terms, we are collecting data on occupation and type of work for these men. We have yet to deep dive into breaking it down, but in terms of those 32% of our disengaged men who are mobile, the vast majority are participating in piecework. So kind of just trying to pick up jobs, either helping build a house or helping with farming, and just kind of jumping around wherever they can find work at the time. And there seems to be some evidence that a lot of these men have other income generation strategies at home, but start moving when that local income generation strategy is not sufficient. So most of these men actually talk about that they would prefer not to travel. They would prefer to work where they are, but they're just not making it. So they're traveling to get whatever money they can.
So, I mean, of course, as you said, this needs to be further explored. But what seems to come out is that they are primarily working in the informal economy.
Yeah.
They don't have one employer. They go and seek work on a daily basis. And that could be another factor stopping them to have continuous engagement with care, because they don't know. I mean, if they go and visit a ART center, they might lose their wages, etc. So those kind of issues you might like to perhaps requires a little bit more discussion. So I'll come back to you, Kath. You want to quickly respond to that?
Just one very quick response to that is completely agree with you. And we're seeing some signal that these men are trying to get refills at another facility, but are often failing. The other facility won't allow them to get an emergency refill. So certainly there's some need to work here within the health system, as well as better understanding what the men are experiencing.
Okay, perfect. Thank you so much. Now let me quickly go to you, Philip. Again, excellent presentation. It's good to see that the message U is equal to U is working, both in terms of reassuring clients, and when you said 59% felt relieved to have got this message. And then you also said that testing got almost double, you know, as a result of this. So this seems to be working very well. The question to you is though, how do you see that this message gets reinforced by the community? Because they get this message, and how do they get this message? So what is the interaction between clinics and communities so that we can maximize on this particular approach?
Yeah, so interesting question. We're fascinated by that. How does that get reinforced along the continuum? So we actually have a study coming up later on this year where we're going to look at what we call booster messaging. What we'll do is we'll have the message, the U equals U message, operating in clinics as well. So men will receive that message outside to test. And then once they're tested and referred into clinic, they will receive that message at the clinic level as well. And then they may also receive a text message booster. And this will be randomized to look at how presenting the message at different stages versus not improves engagement in the cascade.
Okay. Thank you, Philip. I'll come back to you. Now I'm going to pick up a question that's posed by Dora Jave in the question session, and I actually encourage all of you to please post your questions. Dora is also asking a question to Catherine. It's more on the same issue that we earlier discussed about mobility, and she's saying, what do you ask about travel? Do you know how much of it was local travel versus migration or travel across borders?
Yeah, great question. We do. So we, within our baseline survey, and then we will again in our endline survey, ask a module specifically about travel and nights spent away from home. And so for each mobile event, we ask where, if it was international versus local, why they went, what was their social network at the place that they traveled to. This data is still being analyzed, but it's a piece that will be coming out of this. Yeah.
Okay, and I think the second question is also to you, which is posed by Rafaela. Can you please unpack what a positive facility experience means? Does the gender of healthcare provider at the facility make a difference to this experience?
Great question. Yeah, and I think, you know, the exact experience differs a little bit for each individual and kind of what they're looking for. I would say from our qualitative data, some of the kind of core building blocks of a positive experience for men would be that they don't feel like their time's wasted. So either that is reasonable waiting hours, that when the clinic says it's open, that a provider is actually available and isn't completely gone. There's a potential to offer additional services or educational experiences in the waiting space to kind of take advantage of the wait time. I think the second building block is that men feel respected. So the shouting, the being kind of mocked about, oh, you don't know where to sit, you're in the wrong queue, you don't understand, you know, really minimizing this. I think that our men are really sensitive to feeling disrespected. And then feeling cared for, so that there are actual individualized questions being asked. Men are given a chance to respond and actually kind of use their voice within the clinic setting. In terms of gender of healthcare worker, for the general facility experience, that doesn't seem to be as big of a deal within our context, within Malawi. But I would say for HIV specific counseling and mentoring, the gender then matters a lot. And so for a mentorship with HIV, kind of living with HIV, certainly that would need to be a male counselor.
Okay, thank you, Catherine. Very, very useful. So I would also suggest the participants, if you want to ask any questions, please raise your hand. You could unmute yourself and also ask your questions directly, because I've been speaking, I've been trying to read from your chat box, but certainly would like to hear your voice and see yourself as well. So feel free to raise your hand and ask a question. And then we'll pick it up one by one. Maybe when I go back to the chat, the last question, maybe I invite Jamil, you want to come in for your question that you actually have for both the panelists?
Yeah, sure. Thanks, sir. And just to echo earlier comments, that great presentations, interesting data. So thank you so much. I think I'll pose one question to each of the panelists. So I think for Kate Dowell, I think the top line message that stands out for me is that yes, men do disengage, but many of them are actually still in care. We just don't know. We don't have systems to know that and track that information. So I think my question, Kat, to you was that what do we need to do better or differently to try and have a better capture of that information in data systems using, you know, routine data collection measures. I know, because this can be quite intensive and you know, project-based tracking or you know, data merging. So those could be quite intensive. So what can we do on a routine basis to improve that? So that's for Catherine, and then for Philip. Again, so I was wondering, like, what do we need to promote and integrate U equals U messaging better, again, as a standard practice in post-test counseling, for example. And we don't know in many settings that that's not being done consistently. So what would you suggest that we do to improve this? Thank you.
Okay, thank you. Thank you, Jamil. So you can come in, Kate and Stefan and Philip, because questions are for both of you. So anyone can come in first. Okay,
great. Thanks for the question. Really, I think a good question that we're struggling with is what do we do with the data? The routine data, how are there ways and how do we improve it? Particularly given if 30% of these men are actively in care, tracing them is quite an effort, right? So I think a couple things come to mind. First, we're currently relying largely on paper-based medical records. The dream is to be able to move to electronic data systems that connect across facilities. And this would solve a lot of issues around silent transfer. Still currently a dream, but I know it's happening in other places. So that would be a big step in the right direction. And I think the other would be looking to create an environment where it's easier for men to report if they are a silent transfer. So if there was some way that they could fill out a piece of paper, or if there was an app to say, I've moved, send, right? And not have to go to a facility and spend 3 hours to inform their home facility that they're moving. The other is to make it easier for men to report that they disengaged and are now coming back as a re-engaged client. Because there is so much pressure from the facility, and then usually more time spent, sometimes shouting. Men, or anyone, would often, when they disengage, they present as a new initiate instead of a re-engaged initiate. So making it easier for them to be able to come back as someone who's re-engaging, have it not be a big deal. I think we could get cleaner and better data through that as well. But it is a challenge for sure.
Exactly. Thank you. Philip, do you want to come in as well now and respond to, because the question was directed to you as well?
Yes, yeah, thanks very much for that question. So I think there's twofold. There's where's the impact made, and the second somewhat refers to what Kate's been speaking about, that positive experience, the experience that is it's easier, it's convenient, it's fast, and the information is coherent. So what we've proposed to do over the next couple of years is to look at where that impact is made, is to surround participants with U=U messaging, from encouraging to test to linking to care, and then supporting adherence on treatment. And we're keen to see first, where's the impact made with the messaging? Does that messaging continue to impact as it has in the HIV testing phase, linkage and adherence? And then what is it about the message that is impactful? And then I think what you want to do, because what men are telling us is they're not receiving, they'll know that they have a blood draw, but many men are saying they don't know what that blood draw is for, or they've heard about a viral load, and all they know is that it's good or it's not good. And so looking at simply conveying the U=U message, which includes that simple education around the viral load. And so it's to ensure that that's continuous along the cascade. So yeah, that's my response.
Thank you, Philip. I would request colleagues to please raise your hand, but I don't see any raised hand as of now, but I see one actually. This is from, Nina. Would you like to come in, please, Nina Hassan? Please unmute yourself, Nina, and ask your question.
You should be able to.
Yeah. Hi, thanks so much. Great presentations, and wonderful to see the growth of the work in South Africa. Philip, lots of expansion from the work that has been done with Coach and Pilo. So just a couple of quick points. One is that I think this question around what happens at the viral load result return is really important. If you look at the guidance that's out there, both from the US government and I think from WHO, there's a lot of focus on communicating with a patient whose viral load results are poor, right? Because there's lots of concern around viremia. We haven't seen the same level of attention on what to say to a patient whose viral load results are good. And so the answer is usually not very much, but it's an incredible opportunity, as we've seen, to give patients, especially male patients, but really all patients. Our data shows that women are missing this information about viral load suppression and U=U just as much as men are. It's an incredible opportunity to give this message to men. So I just want to encourage all of us here to really focus on that moment. I think that's part of the clinical piece that Kate was talking about that's missing. And also just to point out, I think this is the first time it's occurring to me that a lot of what we've considered silent transfers may be people, especially men, who are migrant workers, just trying to get a refill, right? At someplace else. They may not have ever intended that, like, I'll never go back to the clinic I first registered at. I'm just in a different place and I ran out of medication. And these are all behaviors we should be trying to encourage. Yes, when you run out of medication, go to the nearest clinic and they will help you. So we have to really figure out systematically how to make that easy instead of hard. Thanks.
Absolutely, Nina. Thank you so much, and can't agree more with you. And you have made great points. Would any of our presenters like to respond quickly to what you have just heard?
Yeah, so I mean, it makes me, Nina, I'm thinking about the change in status. So I heard a presentation recently about how the change in status to U equals U was a target for men to reach, was a focus point. So instead of avoiding the viremia or avoiding being bad, it gave participants a new target to focus on, so that I could change my status to U equals U, and I think that's quite motivating. So yeah, I'm saying I agree totally with what you're saying.
Okay, great. Catherine, any response from you on this?
Just to say, also agree. To just share a little bit of data that we didn't present today. Within our interventions in the trials, some of our process data is showing that men have so many questions about U equals U, and that being able to share with them really motivating, interesting messages like what Philip is showing is critical, and then being able to have kind of continued conversations and follow up, because even after they hear it, they still have a lot of questions about, really, is this really, can I actually have a child who won't then get HIV? And so anyway, it certainly is a huge point of interest for these men, and Nina, and I agree, point of interest for everyone that we should really capitalize on.
Excellent. So I see another question in the chat. This is written by Meg Guinua. She said, the question is, thanks, Kate, for the interesting presentation. For the men who are in fact still in care, is there any information on whether they are retesting? Basically, it's about timing and frequency of testing and retesting, and how does that impact re-engagement?
Yeah, good question. For this particular tracing activity, once we confirmed that someone was still in care, we did not ask additional questions about testing. For those who were enrolled in the study and did in fact disengage at some point, we did ask questions about retesting and why that was done. And there is literature, and we've seen something similar where some 25% of individuals living with HIV are retesting, some as a re-entry point into the system, and some because it's being offered and they just don't want to refuse, either as a way to avoid actual status disclosure to people around them. But it certainly is happening. And I think it's something we can explore further within these trials.
Okay, great. Of course, there's one more question, but I think this is something I already discussed. This is by Stephanie. The unpredictability of required work travel is such an interesting finding. Is there any context on what's driving that? Is it a particular economic sector? This is basically the same like what I was asking you about economic profiling of clients. But I think she's also asking, is it that each trip is a new piece job that men find out for at the last minute through a geographical network of some kind? I think you did answer that, but if you want to throw a little bit more light on that, that would be useful.
Okay, thanks. And I think there's actually a rich side conversation going on in the chat around mobility. Yeah, just that it does seem to be largely the kind of piecework that's taking place. And I think importantly, like Marguerite's highlighting, is that the challenges don't just come from international travel, certainly local travel as well. It's anywhere where men are now at a distance from their home ART clinic that is providing some of these issues. And I think thinking through kind of some of the unique needs of these mobile men.
Absolutely. Okay, so before I get more questions from the participant, let me ask actually both of you one question. You said in terms of what seems to be working is that positive experience with service providers is a huge thing. It will reduce the stigma, and it will also make sure that men continue to get engaged. From your experience, what could possibly promote positive experience with service providers? And that's where I think I would like to have both of you make your perspective and share your perspective with us, please. Philip, can we start with you?
Yeah. So in our work, I think what men have said to us is top of the priority is easier and convenient access, fast interactions. So one of the primary interactions that sort of buffets men off of services is having to wait from early in the morning for hours to link to care to pick up their medication. And then there's this other issue of coherent information. And so what happens is particularly around the U=U viral load messaging, many men are saying to us that they've never heard that formulation. They've not heard, they might have heard about a viral load, but some of them don't know what it's for. And if they do know what it's for, it's categorized into a 0 or a 1. It's good or bad. And we're doing a little more work on this, upon hearing the message and having counseling around that message, you will have seen there that there brings relief. But in some of the qualitative work, men are going into depth to tell us that it makes sense, and that's not something that needs to be what I've heard, a mathematical equation, that it can be put simply. And so it's really around, if I could say, convenience is a positive experience, and then having coherent formulations of messaging that's tailored to the participant. I think that makes for a good experience.
Excellent. Thank you. So, Catherine, would you like to add your perspective to this?
I agree. The convenience is huge, and to feel like time isn't being wasted. Again, I think feeling respected and seen and actually like cared for as an individual. I love this idea of coherent information, and agree that it is a big issue. U=U, absolutely. The other thing I would point out that isn't being communicated is this idea of grace or self-compassion with lifetime treatment. And this is something we're working at developing counseling materials around, is this idea kind of as part of a welcome back strategy. You missed your appointment, you missed some pills. It's okay, you're trying, keep trying, right? And as a way to try to minimize the amount of time out of care or without taking pills. And providers seem to be quite nervous about talking about this self-compassion and welcome back, that it may encourage individuals to say, oh, it's fine, I don't need to worry. But really, I think this is a big push. And then the last thing with coherent information would be risk reduction messaging. A lot of providers give very strict, no alcohol, always condoms. And for a lifetime, that's a really hard ask. And so thinking about, can we have more of a realistic conversation around risk reduction on those aspects? So that's my add there, I think.
Thank you very much. And both of you are absolutely spot on. I think this is giving us lots of insights on how to work in this direction so that men who come to facilities have a positive experience. And it's not just for men, it's also for women, and for anyone who goes to a health facility needs to have a positive experience. One practice that we used to do earlier, if you may recall, more so in RCH programs, was to promote service providers, particularly those who are doing good work. We need to get their messages and promote them with their photos, and kind of that used to motivate them a lot to work better and make sure that their work is acknowledged. This has not been done much in this arena so far. Do you think there's a scope for doing that? Like men coming back and saying, having a poster on a service provider who gave great counseling to men, reassured them, and then say that I was very happy to meet so and so. So would that approach work ahead as well? Philip?
Yes, a resounding yes. I think you want to lift up those positive experiences, and you know, in some cases it's positive deviance. You do, and you want to direct traffic in their direction.
Yeah, I did ask this question to you only because yours was more at a communication focused intervention with U is equal to U kind of messaging, and you are doing quite a bit of work around that.
So I could say a bit more about that.
Yeah, sure.
So the mobilizers were trained to give that message, to look into the eyes of their invitees and to deliver this message. So part of the reason that message, what I didn't say, it started off as, I think it was 3 minutes long. And we reduced it until it was the essential core message. And one of the key components was so that the mobilizers looked into the eyes of their invitees and delivered the message. And when they asked the question to stop for a second to register what was going on with their invitee, and we wanted to know, you know, what impact does that have? Because it's not no impact. It's important that, you know, when you're delivering, you're not looking at the invite, you're not looking at the tick box, that you're actually engaging with your participant or patient. And so that was actually built into delivering that message. And so we're keen to understand, you know, what does that interaction, you know, what does it look like, and can you drill it down to its core components so that you're delivering information at a, you know, with emotional valency? How important is that?
Perfect. I see one hand up by Kate. Kate,
just to say, Philip, I love that, and think really appreciate that you are embedding the kind of client-centered approach into the curriculum, because it's so easy to train about it, but then when providers get in the field, it falls away. So I love that you're in the actual job aid embedding the connecting with individuals' eyes, with pausing. I think it's a fantastic example of really structuring the intervention to be client-centered.
Okay, thank you.
Yeah, part of that is understanding, you know, at the clinic level, that nurses are in a rush. Everybody's in a rush. And so the client-centered, you know, it seems as though it's hard to do, but, you know, if we spend a little bit of time thinking about this message was no longer than 40 seconds, and we can spend a bit of time thinking about what's this interaction going to feel like on the other end, and you know, how much of that can push you know, nudge behavior onto the next step.
Thank you both of you. I think we had a very, very good discussion. In fact, I'm very happy that we had only 2 presenters, and so we had enough time for discussions. Before I hand over to Lysias, I would just ask you one last question, and to both of you, and this is extremely important. when I see both of your presentations together, the main message that I get from Catherine's presentation is that men are getting lost to treatment, and they are getting disengaged after starting. And that's a fact. We have the data to show that not everybody is continuing with treatment. So this is one reality, if we may say. In that kind of a reality scenario, the message of U equals U, where we are saying that if you're not identified, would that work? Because in one way it's good because it promotes testing, it promotes treatment. U is equal to U is a great message. But considering the challenges that we have in loss to care, would it be a little bit sometimes detrimental, because those who have got this message that U is equal to U, but they don't continue in care, they would be transmitting. So that would be a potential challenge to me. So how would you like to respond to this? Maybe a quick response from both of you, and then I will hand over to discuss. Thank you. Anyone can go first.
Maybe just really quickly, I think U equals U is a great piece of the toolbox, and certainly is a way to help motivate individuals, men and women, stay on care, even when they feel healthy and there's no immediate kind of reward to them of being in care. So I do think U equals U can help keep individuals into lifelong care, but it is one tool of many that needs to be implemented for a population that's facing a lot of complex multi-level barriers.
Okay. Philip, what about you?
Yeah, that's a hard one, because that's I think the group that is you know, the most difficult to reach is when the information and the tailoring doesn't work. What do you do then? And I think, you know, part of what this group has talked about before is the differentiation of care. And so thinking about, you know, that hardest to reach population, it certainly is differentiating care. And what we find with men is that you know, you reach into the community, for men, but also for partnerships, and saturate the community with not just the U equals U message, but care. And you know, that is to reiterate, is the hardest group to reach. Yeah.
Okay, thank you so much to both of you for your insights, and it was great moderating this discussions, and I'll hand it over back to Lysias. So Lysias, over to you.
Thank you so much, Afsa, and thanks to our excellent presenters. Philip, Kate, thank you so much for this enriching discussions, and thanks to our participants also who have been coming up with these engaging questions. I want to give to Wale to give us closing remarks. From me, thank you so much. We will continue, we will follow up with your poll responses to follow up with those who are interested in presenting in this platform. As you can see, it's a very engaging platform. You present your work, you are also able to get some good feedback on this platform. And also it allows others to learn what you're doing. I look forward to seeing more work done in other regions as well. WCA, the data shows clearly that also this gap on men and HIV, it's quite wider in that region. It'll be interesting to see what is happening, or what activities are being done to address this issue in that region, as well as other regions as well. So over to you, Wale, for the closing remarks. Thank you so much.
Well, thank you very much, Lysias. And let me just say, you know, really fantastic presentations, but also fantastic discussions. You know, we intentionally try to have just a few presentations, so just 2 presentations, so that we can have a lot of these discussions. And I think, Afsa, you have, you know, done really well to moderate and facilitate over such a, you know, quite a time as well, to bring forth questions, suggestions, comments all of which, you know, I was sitting here looking at the chat box and thinking, you know, this is exactly what we need. We need to be able to have this sort of platform to, you know, to move away from what we thought was the situation, where we were thinking we didn't have a lot, you know, to speak about on men. We didn't really have a lot of the data and so on. But I think we're moving from that now. And thanks to, you know, work like this from Kate, from Philip, we're getting to see and to have a better understanding of men and exploring, you know, atypical areas that we wouldn't really sort of get nuanced understanding about. So I want to really thank you for that and to say, you know, kudos to you, but not just to you. I'm sure, you know, like you presented, you have a team, you know, of people who are working with you to get this to us. Part of the chart, and you know, I'd like to just say this, you know, very briefly as well, is you know, about changing the narrative about men, and I think we saw this very clearly from the presentation, particularly from Kate's presentation. I've seen in the chat box from Nina, from Mona, you know, trying to see how the things that, you know, we're sort of demystifying a lot of the things that we thought were true. You know, in the past, we would think, you know, men didn't want to come for care, men didn't want to come to facilities, but, you know, we're changing from that. We're seeing, you know, hardcore data that is, you know, moving us and tilting us away from that to see how, you know, we can better respond. We've seen from Kate's, you know, great presentation as well, you know, the idea that men, you know, disengage from care, but, you know, have they really disengaged? No, they haven't. If we look at, you know, what, well, in large parts or in some parts from what Kate presented, you know, it seems as well that we are disengaging from men based on, you know, preconceived, notions and ideas. We need to begin to form that relationship back, you know, begin to build that trust for men to be able to get the care that they need and they deserve. And then finally on that point is about, you know, making sure that we use the advantage that we have to ensure that we turn the sort of discussions that we have here, the sort of data that we're getting, we start to begin to actionalize them, to make them actionable and reduce that gap between the understanding, the seeing, the analyzing of those of the data to turn them into quick actions and solutions. And that will require us moving at, you know, a double quick pace. We don't have a lot of time. You know, I'm seeing a lot as well where the sort of urgency that we had in the past, you know, we need to bring that back to say that, you know, we're a decade, probably less, to 2030, where we have this lofty, you know, ambitious goals to having those 95 targets. We need to be able to now move forward with purpose and with urgency, you know, towards reaching where we need to reach. You know, very interesting from Philip, and you know, I listened, you know, with rapt attention to, you know, to the presentation of U equals U, and I think my final reflection on that is just, you know, a broader message about the power of communication, the power of language and of messages. I think this is really, really important. You know, tweaking, you know, simple tweaks to our messages and our communication can make, you know, really great effect. Just recently, you know, I was having a conversation about how, you know, we've made really great progress from, you know, the 80s, the 90s, the early 2000s, you know, to put people on treatment. But it just seems like while we've made progress, we've still stuck with, you know, certain outdated misconceptions and terminologies, which we need to begin to see how we can, you know, consciously move away from. I take the really great message from a few in the chat box, but also from the presenters, you know, who say that in giving that message about U equals U, we need to make it holistic. You know, we need to provide messages that are coherent and make sure that those messages aren't misconstrued, you know, certainly, because that's our role. Our role is we want to be able to give messages that are useful, that are coherent, and that can be helpful at the individual, but also at the population level. Undetectability, of course, is not a one-off event. You know, it takes a process. You know, usually when you start ART, you know, usually between 3 to 6 months, if the treatment is working, you should be able to get, you know, to viral load levels that are undetectable. However, there is, of course, work to be done in, you know, reinforcing the messages on adherence and so on to make sure that those messages on U equals U are strong, they're coherent, and that can, you know, help us to get to you know, where we need to get to in terms of targets. Great quote, Richard, on you know, let's think differently. You know, I just added as well that, you know, we need to speak differently. We need to speak with, you know, like Kate mentioned, you know, with compassion. We need to speak with the language that men understand, so that we can, you know, get those moving. Finally, I'm just going to you know, say that the webinar series, like you know, we have dates that are scheduled already, and you can see them on the screen. We would love you to you know, spread the message. There's so much information that is going on here, such a great community that we're beginning to have. So spread the word. Let's have people, you know, join in more on these dates. So the next one is on the 18th of May, and then the next on 14th of September, and then we'll round off in a big way in December, just around ICASA time. So I'm going to have to just say, you know, thank you all for joining. It's been a huge pleasure. I'd like to thank, of course, in no particular order, the co-chairs of the Men and HIV Technical Working Group. So that's the, you know, the nice, beautiful poster you see on the screen. This is a group now that we have. It's a sort of steering group that we want to see help steer the work and coordinate the work that we're having on men and HIV. And I have to tell you, we have such exciting products, activities that are coming up for the year. So watch out for this space as we share those with you as time moves on. Of course, to the fantastic presenters, you know, Philip, Kate, you did more than an amazing job, and I hope that we can always call on you and count on you to continue to avail us your time, but also your expertise and your experience on this vital topic. We've had this interpreted in different languages. Lisa has mentioned that, so I'd like to thank, you know, all of the interpreters, the technicians who have made this very smooth webinar. And then finally, of course, to all of you, you know, all of you that have attended, you know, but also engaged. I was looking at the introductions, and it's just a wide, you know, diverse, you know, group of people that we have here. And I want to just say a huge thank you for continuing to support and to advocate and to push this very important agenda. See you soon, really. Thanks to Lysias, of course. Lysias has, you know, organized this, you know, very efficiently. So thanks for taking the time and the effort to bring us all together. We'll see you in, you know, very soon as those dates show. And, you know, thank you so much, and looking forward to continuing this discussion. Bye, and take care.
Bye-bye. Bye, everyone.